Hi, welcome to our Menopause and Me video series, where we bring you the contributors from our very successful Menopause and Me webinar, which we hosted as part of World Menopause Day in October 2021. We hope that each of the 5 videos will support you in accessing the information you need at this time. My name is Mairead Kelly and I'm a Senior Health Promotion Officer in Midwest Community Healthcare. I invite you to watch each video as you search for support, affirmation and answers to your own individual perimenopause or menopause journey. I wish to introduce you to our first video brought to you by Dr. Cassie Mc Veigh, who specialises in menopause and its management. Dr. Cassie will guide you through your medical queries relating to both perimenopause and menopause. I hope that you find some reassurances and answers to your questions here. Thank you.
We're going to look at menopause. What actually is it? How do we diagnose it? What are the symptoms? And what's HRT and what's that all about? So our first speaker tonight is a lady called Dr. Cassie Mc Veigh. She's a vocational trained GP with special interest in menopause and its management. Dr. Mc Veigh is passionate about education and empowering women to manage their menopause through evidence-based medicine and lifestyle modification so that they can live a healthy and fulfilled life through their menopause and beyond. Dr. Mc Veigh, you're very welcome. Over to you.
Thanks very much. So thank you very much for asking me to speak at the Menopause and Me webinar tonight. It's a real honour to be here with everybody, and I'm really looking forward to learning a lot more over the course of the evening. So I work in Sligo, both as a GP, and 2 days a week I work in my clinic called Vitality Clinic, which is pretty much exclusively manages menopause for women and discusses lifestyle and so on with them. So I'm really enjoying doing that at the moment. So menopause, what is it? It's defined as the end of the menstrual cycle, and it results from the shutting down of the ovaries, marking the end of our reproductive years. So during our reproductive years, our ovaries produce most of our estrogen, progesterone and testosterone. And the average age of menopause in the UK and Ireland is 51. It's something all women are going to go through if they live long enough. And a woman is considered postmenopausal once she's not had a period for 1 year and is not on hormonal contraception or doesn't have any other explanation for her lack of periods. A surgical menopause is when a woman has her ovaries removed. This can occur at any age, such as in women undergoing surgery for a gynecological malignancy like cervical cancer or something like that. Women can also go into menopause from cancer treatments, such as chemotherapy and radiation. And as the lovely smiley lady with the red lipstick was talking about, how some of the breast cancer treatments can basically shut down your ovaries and put you into a menopausal state. Women with autoimmune disease, such as thyroid disease, rheumatoid arthritis, they have a higher risk of premature menopause. And menopause for some women, and I see this quite frequently, can be precipitated by an emotional trauma, such as the death of a parent, maybe a marriage breakdown, that kind of thing. So perimenopause is something we've been hearing a lot about at the moment, and perhaps before this year, a few people maybe had heard of it at all or knew what it was. Perimenopause refers to the time around the menopause, and it's also called the menopausal transition. Women will start their perimenopause at different ages. We usually say that around about 10 years before the age of menopause, women will develop very subtle symptoms which can begin as early as the early 40s or even late 30s. Perimenopause tends to be a bit of a roller coaster because it's a time of hormonal fluctuations where 1 minute we can have high estrogen and the next we've low estrogen, and that can lead to days or weeks when we feel okay and other times where we feel awful. So it's hard to kind of know what's going on. In terms of symptoms of menopause or perimenopause, so the symptoms of both are kind of similar. There's about 33 different recognised symptoms of menopause, but there are likely to be many more than that. We use a system called the Green's criteria for, it's kind of a questionnaire that women can fill out. It's available on my website, but it's available in lots of different places. And you can fill that out where the symptoms are graded 0 to 2, and you use that to sort of assess how menopausal you may be. There's also an app called Balance App, which has been released by Louise Newson's team over in the UK. It's a really good app for learning more about your menopause, tracking your symptoms, that kind of thing. And I know a lot of women are involved in the Irish Menopause Facebook page, which has been really massively helpful for women gaining information and support for each other. So traditionally we thought of menopause as hot flushes, night sweats, maybe a bit of moodiness, some tearfulness. But now we're starting to recognise that the symptoms of menopause and perimenopause are much more nuanced than that. So in my clinic, probably the main symptoms I see are poor sleep, migraines, new onset of anxiety, loss of self-confidence, including loss of body confidence, low mood, palpitations are very common, tiredness, loss of sex drive, painful intercourse, weight gain, aches and pains, particularly in the shoulders, and weirdly the thumb joints tend to be a really common place as well. I just want to mention weight gain specifically because it probably affects most of the women I see, and even affects women for whom weight has never been an issue. And as we lose estrogen, we become sort of more apple than pear shaped. So we tend to become more of a shape that we would traditionally associate with men. And when we put on weight in that area, we start to see an increased cardiovascular risk. So that's an increased risk of heart attack and stroke. It's worth mentioning women who smoke or who are overweight do tend to suffer from more hot flushes and generally have a tougher menopause than women who don't. And I think the main point is that every menopause is different. So you won't necessarily menopause the same way as your mum, although you may menopause at a similar time as your mother. You won't menopause like your sister or your friends. And because of that, a woman's menopause will need to be managed differently for each person. And there's no need to fail just because your menopause seems to be particularly tough that you're failing in any way. So why is it so difficult to get help? I guess we failed in an education, in the area of education for women. So women aren't educated in what to look out for in terms of the menopausal symptoms. So they don't really know what's wrong with them when they can't sleep, or they become very anxious or forgetful or unable to cope. So lots of women go on Google and they end up thinking that they have dementia, or they have something wrong with their heart, or that kind of thing. It's also difficult because some healthcare providers are not trained to recognise these symptoms as menopausal symptoms, although thankfully this is rapidly changing with recent public menopause awareness campaigns and increasing access to menopause training. As doctors, we were taught for many years about the dangers of HRT, and we were told that if we had to prescribe it, to give it at the lowest dose for the shortest time, and it will take quite a long time for this thinking to change across the board. But personally, I have to say, a lot of GPs I know are excellent in the management of menopause, and I think that's a good thing to know. It's important to mention that women in lower socioeconomic groups and those in ethnic minorities in general have less access to education on menopause and less access to HRT. So this is an inequality that needs to change. And hopefully with the new menopause clinics which are planned in the HSC and more availability of education for our GPs, it should improve access to good menopause care for all. Talking about menopause in the workplace, given that we're talking within the HSC setting, 40% of the workforce in the NHS are menopausal, and it's probably fair to extrapolate that number roughly to the HSC as well. A poorly managed menopause is a very common factor in women deciding to cut back their hours at work, not going for promotion, or taking early retirement. And this is a shame because it coincides with the time in life when they have the most to give in terms of knowledge and experience in the workplace. Society has to realise that menopausal women are amongst the most valuable members of the workforce, and that a well-managed menopause in the workplace is a positive thing for all of us. In terms of home life, we often talk about the sandwich generation, and that refers to a time in life where women have maybe teenage children. So they say puberty is a bit like a reverse menopause. So there's a little bit of a clash of hormonal issues in many families. Aging parents can cause a burden of care, escalating work pressures, relationship pressures, particularly for same-sex couples. It can be especially difficult because they can both be going through the menopause at the same time and perhaps having very different menopauses. So that can put a lot of stress on couples too. The recent trend to talking about menopause can only be a good thing, in my opinion, in that close members of our family and our work colleagues can have an insight into the changes that we are coping with. How do we diagnose menopause? So in women over the age of 45, the NICE guidelines, which are the guidelines that GPs and other doctors operate under, recommend that we diagnose menopause without blood tests and base it on clinical symptoms. In women under 45, the guidelines recommend blood tests just to rule out other potential causes of symptoms, such as an overactive or underactive thyroid. In practice, it's probably a good idea to have an up-to-date thyroid function test for all midlife women because symptoms of thyroid are very much like the menopause, and indeed, they often go hand in hand in this age group of women. The other blood tests we do very commonly is an FSH or an LH, and these are the follicle-stimulating hormones and the luteinizing hormones. If these are elevated, they can signal a woman is transitioning to menopause, but they could be up and elevated one week and they could be normal again the next week. So just because they're up once doesn't mean that they're going to be up a second time as well. So I suppose the take-home message here is that normal hormonal bloods in a woman under 45 do not mean that she is not suffering from menopausal symptoms. And so clinical history is the most important tool in diagnosis at all ages. What to consider at the time of menopause. So when I see patients, I look at it as a really good time to take stock of things, looking at our lifestyle, putting into place changes that will stand to us in terms of our best future health. So it's not just a time to survive, it's a time to thrive. I always chat to women about their diet, frequency and type of exercise leaning towards weight-bearing exercise, but also bearing in mind that the exercise you do has to be something you like or you're not going to stick at it. I talk about smoking status. It's a really good time to stop, as any time is, and alcohol intake. Just a quick word on alcohol. I find it's a particular issue for midlife women. Women often start to drink more around the time of the menopause to cope with symptoms such as anxiety and poor sleep. But unfortunately, we know that alcohol generally leads to more problems than it fixes, and many women find it actually makes their menopause symptoms worse. Dietary factors such as adequate vitamin D, calcium, and omega-3 oils are what I recommend for pretty much all of the patients, but I know somebody will be going into this in more detail later on. Pelvic health is important. Issues with vaginal dryness, incontinence, painful intercourse. That's important for all women, whether they've had children, whether they're sexually active. A healthy vagina is really important for all of us. Also screening, making sure smears and mammograms are up to date. A mammogram is not indicated when starting HRT, but it's a good idea to make sure that if you're over 50, you're registered with Breast Check. DEXA scans can be done to assess bone density. They don't need to be done for all women. So your doctor can use a tool called the FRAX tool, and that's available online. And using the FRAX tool, we can determine whether you're high, medium, or low risk and determine whether you need a DEXA scan based on that. Before we talk about HRT, I just want to quickly mention some non-hormonal options for menopausal women. And this is especially important for women who, for whatever reason, cannot have HRT, such as a history of hormone-dependent cancers. In these women, lifestyle becomes particularly important because it's their main weapon in the armory against menopause. In women with hot flushes and low mood, antidepressants can be very helpful, and there are a number of other medications which I won't get into here, but could be discussed with your GP or healthcare provider. Sadly, there's not much in the way of evidence for nutritional supplements, with the exception of red clover extract, which does have some evidence in the reduction of hot flushes. Lots of women take black gohash as well and seem to find that it helps. The evidence isn't great for that, but you know, if it helps, it doesn't really matter if the evidence is there or not. CBT and yoga have some good evidence for the reduction of hot flushes. And interestingly, we know Japanese women experience fewer hot flushes and night sweats, which is likely because of their high soya diet. A vegetarian diet or one lower in meat has been linked to fewer hot flushes. Brain exercises are important for the brain fog. That'll be puzzles, jigsaws, crosswords, that kind of thing. Lots of women find acupuncture, reflexology, and other alternative practices really helpful. And while the evidence is scant in this area, each woman is different, and many women report great benefit from these approaches. So in my opinion, whatever works for each individual woman is the most important thing of all. So in the discussion of HRT, I suppose I'll start with the elephant in the room, which is always breast cancer. Just to say, our baseline risk of breast cancer as females is pretty high. So it's roughly 1 in 7 or 1 in 8. Some of us have higher risk factors and some of us are a little bit lower. The biggest risk factor for all women really is obesity, and the biggest reducer of risk is regular exercise. The good news is that women who are diagnosed with breast cancer, 90% of those women will still be alive at 5 years following their diagnosis. So although it's a very shocking and difficult diagnosis, the treatments have got so good these days that most of the women will survive and thrive following a diagnosis of breast cancer. So why is HRT linked to breast cancer? So roughly 20 years ago, a number of studies came out linking HRT to breast cancer. The main one of these was the Women's Health Concern. It's probably the best known. And it was later shown to have been incorrectly reported, and it resulted in millions of women stopping HRT. This resulted in a higher incidence of heart disease and fractures, but it didn't have a huge impact on the incidence of breast cancer. In fact, breast cancer incidence didn't really decline at all, despite how many million women stopped taking HRT. So how many additional breast cancers are we talking? So the Women's Health Concern reported an additional 4 cases of breast cancer per 1,000 women aged 50 to 59 taking continuous combined HRT. So that's roughly 1 case per year per 1,000 women. To put this in context, women who drink a large glass of wine every day have an additional 5 cases per 1,000 women. So that's 1 higher than taking HRT. Women who have a body mass index of over 30 have an additional 24 cases of breast cancer per 1,000 women. Women who take the combined oral contraceptive pill, so that's the same pill that we give our 16-year-old daughters, and I'm sure we took ourselves, they have an additional 4 cases per 1,000 women, so that's the same risk as taking HRT. And interestingly, for women taking estrogen-only HRT, so that's women who've had a hysterectomy, the risk of breast cancer was actually found to be lower in those women than women not taking HRT. So it's generally considered that estrogen is not a carcinogen in that it doesn't cause breast cancer, but it accelerates the growth of abnormal breast cells, which were already present before starting HRT. It's worth remembering that women diagnosed with breast cancer whilst on HRT do not have a higher risk of death than those diagnosed with breast cancer who are not on HRT. So what are the big killers of women? Osteoporotic fractures, heart disease and stroke, and dementia. And what do women who get breast cancer ultimately die from? The vast majority of them die from heart disease, stroke, osteoporotic fracture and dementia. So in terms of osteoporotic fractures, women have a 1 in 6 lifetime risk of a hip fracture. So they have a higher lifetime risk of a hip fracture than they do of breast cancer. And of women who fracture their hips, 30% of those women will be dead within the first year of their fractured hip. And that could be from blood clots, hospital-acquired infections, those kind of things. We're not talking about elderly women here, particularly. We start to see hip fractures in women from their 60s and 70s onwards. So why is modern HRT considered to be safer? So the studies that we mentioned before, we're looking at women using older types of synthetic hormones at much higher doses than we now use. The women were of an average age of 62. So they were quite a bit older than the women we commonly prescribe HRT for or start HRT on. Many of them were suffering from obesity, and the HRT they got was administered orally. So it's generally not a good comparison to the HRT we use now. We use body identical hormones these days, which are derived from yam root extract. These hormones are very similar to what we produce ourselves. We use them in lower doses in younger women, and the estrogen is given through the skin. So in terms of benefits of HRT, we see a reduced risk of osteoporosis and fractures, reduced risk of heart disease and stroke. Those are both in the region of 30 to 40% reduction. Potentially there's a reduced risk of dementia. So the studies are kind of in their infancy for dementia risk, and there does seem to be more reduced risk the earlier you start your HRT. So the sooner after you finish your periods or even in the perimenopause seems to be more protective for dementia. HRT is a recommended treatment for low mood in women as a result of the menopause. Many women report more energy, reduced aches and pains. It can often help with migraines, which do tend to become more common around the time of menopause. But it is important to note that HRT is not a panacea, and women may have other causes for their health issues. So we can't blame everything on the menopause, although it has a lot to answer for. So in terms of accessing HRT, modern HRT is a very safe product when used through the skin in a twice-weekly patch or gel. Whilst not everybody wants to take HRT, I think women should be aware of the long-term benefits of it so they can make an informed decision. There are very few women who are not suitable for this type of HRT should they wish to take it. So those with a family history of breast cancer, personal or family history of blood clots, women who smoke or are obese can all safely be prescribed these products. This type of HRT is widely available through your local GP. So you don't need to come to a menopause doctor to get your HRT. It's also available free of charge to those with a medical card. And do bear in mind that it might take a few visits to your GP to get started on HRT. There's a lot to discuss. Maybe bring a Green's criteria questionnaire with you so you can think of your symptoms more easily. You need your blood pressure well controlled and your other cardiovascular risks well managed. So that's your cholesterol and things like that. After starting HRT, you should be reviewed at 3 months and then once a year. It can often take time to notice an improvement, and for some women it can take a few adjustments to get the right regime. For example, some women would find that a patch works better than a gel. Some women do better with synthetic hormones or synthetic progesterone than body identical progesterone. So everybody's different. HRT can be taken for as long as the benefits outweigh the risks, which, other than the development of a hormone-driven cancer, usually tends to be indefinitely. Common side effects are bloating, breast tenderness, and vaginal spotting. These usually settle within the first 3 months. It's worth noting that any bleeding more than a year after you finished your period should be investigated, whether you're on HRT or not. And vaginal bleeding after 6 months on HRT may need investigated too. All women are suitable for vaginal estrogen, which can be given very useful to reduce urinary tract infections and make intercourse more comfortable. So just to finish on a positive note, I'm really happy to be involved in menopause care for women at a time where it's finally becoming a mainstream topic of conversation. Women are educating themselves and supporting each other through this difficult time in their lives so that they no longer have to feel ashamed and isolated by their symptoms or feel that they are giving in by choosing to opt for HRT. I view the menopause as a time for positive change, to get ourselves in the best health we can, to ensure that we are able to live into old age with the best health possible. Thank you for listening.
Dr. Mc Veigh, that was really wonderful, so informative. And I just want to say to everybody, tonight's session has been recorded. So if any of you want to watch back on any of the presentations, just in case there's detail you missed, you will get the recording in the next week. So look, that was really wonderful. I learned so much myself. Thank you so much.
Thank you.